Good evening, everybody. For us, good evening, good morning, or good afternoon, depending on where you're at. We are at the 24th hour of this marathon educational town hall. We are still waiting for Dr. Jung, our moderator. However, Dr. Lau will get us started. Dr. Lau is an orthopedic surgeon in Toronto, a good friend, and he will talk to you about some bone stock issues. Dr. Mcgarvey was not able to be with us in person today, and so we will have a video from him. And then hopefully by then we will have Dr. Jung convene with us. Johnny, it's up to you.
Thanks, Selene. Congratulations. Can everybody see my screen?
Yes, we can.
And audio's good?
You got it.
All right. Thanks, Selene, for hosting such a wonderful event. And we're on the last hour. And thanks for the invitation to speak about total ankle replacements in rheumatoid arthritis patients. These are my disclosures. In particular, I am a designer and consultant and receive royalties for the Zimmer Baumet trabecular metal ankle. This is not too different from the rheumatoid arthritis patients we see. They tend to be on the younger side, 40-year-old female, a long-standing history of juvenile rheumatoid arthritis with right foot pain. First thing that strikes me, I'm concerned about her age. Also, the prolonged period of rheumatoid involvement, and most likely the use of steroids and probably other biologics, which will have a negative impact on her bone density. And also the multiple joint involvements that's left her with deformed hindfoot joint with significant arthritis at the talonavicular and the subtalar joints. Total ankle replacements are recommended in patients with inflammatory arthritis when the rheumatoid arthritis is controlled. The bone strength is augmented because there's significant concern for the prevention of talar component subsidence, and that we can obtain soft tissue balance and realign the axis. And the three big concerns in this population are immunosuppression, bone quality, and wound healing. Perioperative anti-rheumatoid arthritis medications, according to the American College of Rheumatology, as well as the American Association of Hip and Knee Surgeons, would include continued use of NSAIDs at the current dose. Disease-modifying agents also are continued through surgery. Steroids are tapered to less than 20 milligrams a day prior to surgery. And biologics are stopped prior to surgery and resumed at a minimum of 2 weeks after surgery. So going back to this patient, most of her problems are really in the hindfoot due to the arthritis, the talonavicular joint, the subtalar joint, and the malalignment. This is treated successfully with a triple fusion. However, 6.5 months later, she develops progressive ankle pain as the joints in the ankle take more load and begin to deteriorate. 6.5 years after total ankle replacement, she's had excellent relief of her symptoms. And many would argue that even though she's young, she's got multiple joint involvement and she may not be as active as someone without rheumatoid arthritis who is the same age. However, my biggest concern in this group of patients who are younger is the longevity of the implant and where the cysts and the component subsidence will be a problem with time. If we look at the survivorship of patients with inflammatory joint disease, 84% at 8 years still have their implants. And looking at an older trial by Woods, up to 80% at 10 years still have their implants. Dr. Schoen did a large meta-analysis looking at 30 articles with 5,508 patients.
And
they were broken down into inflammatory arthritis with non-inflammatory arthritis patients. The average age at the time of surgery for the inflammatory group was 58 years, whereas in the non-inflammatory arthritis group, it was 63 years. The average follow-up was similar between both groups. This is a chart representing all the papers that were used to evaluate this meta-analysis, and clearly looking at these studies, they include implants, some of which are not currently used. So this results of the meta-analysis must be considered carefully. This is the forest plot of the preoperative AOFA score, which is not different between the inflammatory and non-inflammatory group. This is the post-op final AOFA score between the inflammatory and non-inflammatory group. Again, no significant difference. And this is the complication rate. The revision rates in the non-inflammatory arthritis groups were significantly higher in this meta-analysis. And the survival rates between the non-inflammatory and the inflammatory arthritis group at 10 years showed no significant difference. Clearly, these studies, this meta-analysis has limitations, since all these studies were small case series, retrospective, short to medium term, and few trials compared the outcomes of two underlying conditions. These were all pooled data, and these older studies didn't really have biologics like we do nowadays. So really, we should be considering more modern literature, even though this meta-analysis was just published in 2023. This is a modern trial, but it's not done with the commonly used implant in North America. It's a Zenith total ankle replacement. And they looked at 67 patients with a minimum follow-up of 3 years. In this group, they had patients with osteo and rheumatoid arthritis, and there was no clinical significant difference in the outcome scores, and both groups improved significantly post-operatively. The osteoarthritis group had better sports activity scores compared to the inflammatory group, and both active range of motions improved in both groups. The complications after surgery were also similar between the osteoarthritis and the inflammatory arthritis group, with similar rates of malleolar fracture, wound healing, wound complications, and infection. And even the early complications that they observed in this small short-term cohort showed no significant difference between the two cohorts. And even stopping the rheumatoid drugs did not affect any flare of the rheumatoid arthritis. And also in late complications, there was no significant difference in this cohort. Non-revision surgery was performed in both groups for the inflammatory and the non-inflammatory, consisting of arthroscopic gutter debridement, and revision surgery, again, in both groups. That was not significant. This is a very interesting study published in 2017 from Japan, looking at a fine total ankle replacement system with 50 ankles. It was a retrospective observational study with an average follow-up of 7.1 years. The outcome scores used significantly improved. But what was interesting is that they also broke the group down into patients using biologics and patients not using biologics. 48 of the 50 ankles had no revision surgery. Subsidence of the talar components were seen in 8 ankles, 6 on biologics and 2 on non-biologics. 2 of the ankles in the biologic group had to undergo revisions. This is the table showing all the complications observed in this cohort of rheumatoid arthritis patients. The most common being intraoperative malleolar fracture, delayed union of the malleolar osteotomy, subsidence of the talar component, radiolucencies around the implant, and delayed wound healing. In table 8, it also shows a very interesting finding that when they developed subsidence of the talar component, the total ankle replacement needed to be revised significantly greater. Furthermore, they also showed that this patients with rheumatoid arthritis that underwent a subtalar fusion had a higher incidence of talar subsidence. So maybe that subtalar fusion alters the blood supply or the density of that bone. Talar component subsidence was a huge concern in this cohort, and they observed it more frequently in patients with biologics. And it's kind of counterintuitive because this cohort generally uses less prednisone. So by using less prednisone, it would usually decrease your osteoporosis. And some of the biologics like anti-TNF and anti-IL-6 receptor therapy inhibits cytokine, which prevents bone loss. but there may be other factors like the duration of the steroid use, immobilization, and how long they've had rheumatoid arthritis. Looking at complications, ideally you want to avoid in this cohort, but fracture, infection, cysts, subsidence, and loosening is all part and parcel with doing these complex procedures in this challenging population. This is a 68-year-old patient with psoriatic arthritis and biologics treated with disease-modifying agents that had a total ankle replacement with a mobility implant. Any notching around the malleoli, I would routinely perform fixation for to prevent fracture. In this population, it's very easy to contour the joint with the saw, with a burr, with a mill, and as the implant is reduced, if there is a little stress riser in the medial or lateral malleoli, as you apply tension to the joint, the fracture can propagate. It's always easier fixing it prophylactically rather than fixing it after it fractures. This is a 73-year-old patient, really with end-stage post-traumatic arthritis, who had a Zimmer total ankle replacement with a plate that was fixed in standard fashion. Unfortunately, 6 weeks later, she still had wound healing issues. This can't be treated with simply just antibiotics because unfortunately in this population, especially in the rheumatoids who have soft tissue issues, immunocompromised, you can't leave the hardware that's infected. The hardware has to be revised, it has to be removed, and the alternative hardware has to be used. So the plate was removed, a K-wire was inserted, and 1 year later, the fibrous artery hasn't fully healed, but it's a stable fibrous union that gives her excellent pain relief and no change of the implant or of the osteotomy. The 63-year-old male who has end-stage arthritis that has a total ankle replacement and 5 years later starts developing cysts around the implant. You commonly see this in two mobile bearing designs due to the backside wear as well as wear underneath the component. This is another 60-year-old patient that had a total ankle replacement 1 year later. 5 years later, you could see the cyst forming just under the tibial component as well as under the talar component, and even larger cyst at 7 years. And at 9.5 years, the cyst is so big that it fractures. The cyst is bone grafted and fixed with this plate to reinforce the fracture. But unfortunately, it develops delayed wound healing. And it almost makes you reconsider whether we should be using big plates, especially in these patients that are older with more compromised soft tissues, and especially in these rheumatoid patients. What happened to that patient with the total ankle replacement that we saw earlier with the prophylactic screw? Well, 11 years later, she is 77 years old. The talar component has subsided. Her arthritis is largely burnt out, but she's in a wheelchair because she can't walk due to pain in her right leg. This was revised with a TTC nail, and as you can see, there's packing in the wound because the lateral wound continues to drain. And she's on chronic suppressive antibiotics because she's unwilling to accept baloney amputation. And this was during COVID. And I get a phone call saying that she's not feeling well and she can't walk, and the nail has cut out inferiorly. This was revised to another nail and packed with antibiotic cement. And so far, she remains on chronic suppressive antibiotics with no wound breakdown. But it brings up a very important point that we have to consider. How well do these salvage ankle fusions do? In this retrospective review that Norman Espinoza conducted, looking at salvage fusions for failed total ankle replacements versus primary fusions, the salvage technique was standard, either with an anterior or lateral approach, and it was done through the primary arthrodesis was done to an anterior lateral approach. He looked at 50 patients with, he looked at salvage arthrodesis versus a primary arthrodesis, and the fusion rates were about the same. But what they documented, most importantly, was that the salvage arthrodesis led to impaired quality of life and reduced function compared to significantly higher pain and significantly higher pain compared to the primary fusions. Thus, he concluded that caution is advised when explaining conversion of failed total ankle replacement into fusion, since it will unlikely be as successful as the primary fusion. In conclusion, successful total ankle replacements in rheumatoid arthritis patients require control of the inflammation, optimization of the bone stock to prevent subsidence, soft tissue balance, and restoration of the anatomic alignment. In the future, we need to preserve bone stock to improve the chances of revision total ankle replacement. We also need better revision total ankle replacements that have greater longevity. Clearly, as we've seen in other failed implants, like in big toe fusions and in failed total ankles, the primary fusion does better than a revision arthrodesis. If we don't have better options to revise total ankles, or if we don't improve our options for these fusions, it becomes very challenging to consider total ankle replacement in 40-year-old patients with rheumatoid arthritis, since the revision to the TTC fusion will occur in their lifetime, and they do very poorly. I'd like to thank you for this opportunity to speak at this event. And we concluded our 50th biannual meeting last year. So I look forward to welcoming people to Toronto in 2026 when we host the World Cup. Thank you.
All right. Thanks, Johnny. Dr. Jung, you're up.
So hello, everyone. It's my great pleasure and honor to be here to participate in this 24 hours webinar related to my section with problematic ankle arthritis performed with total ankle arthroplasty. So as Johnny Lau talked about osteoporotic rheumatoid arthritis patients, my topic is about total ankle arthroplasty for varus and valgus ankle OA. I have nothing to disclose related to this my talk. So ankle arthritis for total ankle arthroplasty are well, on the left picture is quite normal looking line, but in many cases of ankle arthritis, you will find a quite deformed of the alignment with the deformities, and also some morphological deformities of the talus. So that's why in total ankle arthroplasty compared to total knee or total hip, you need a lot of combined surgical procedures in during the arthroplasty, such as, of course, for the steep ankles, Achilles tendon lengthening or calcaneal osteotomy, or first metatarsal osteotomy, ligament release, reconstruction, or combined fusions. So total ankle for varus ankle OA, it's a good indication at present for, and but varus ankle arthritis is actually not uncommon. But before, it has been relatively unrecommended for the quite varus or valgus ankle arthritis for relative contraindication for more than 15 degrees or 20 degrees absolute contraindication only in the early 2000s. But now, total ankle is rather a good surgical option for ankle arthritis with significant ankle deformities. As for the etiologies, idiopathic distal tibial ankle fracture malunion can be some of the reason, but in my practice, when I went through a lot of patients with varus ankle OA, the main reason is chronic lateral ankle instability. For the long-standing instability for at least more than 10, 20 years. Also, there can be some varus foot, which are can be the reason for this varus ankle arthritis. To measure these radiographic parameters for coronal alignment deformities, Usually the basically tibia anterior surface angle, talar tilt angle, and I find it important to measure the talar dome ground surface angle. Others are tibia axis talar dome angle. So I think we should define the varus ankle arthritis by one of these radiographic parameters. But not just by saying that it's varus ankle, but you should present the angles, how to define the varus ankle arthritis. So I'd like to show you some of the cases that I've experienced to share with you. This is a 71-year female patient with congruent varus ankle, performed just with total ankle arthroplasty, a deep data release. So as you can see, I usually take the long leg standing view, and you can see the hind alignment is relatively rather valgus, compensation at the subtalar joint. Tibia cutting angle and corona position relative to both malleoli is the most important stage for total ankle procedure. I usually cut about 3 to 5 millimeter thickness at the plafond apex. So tibia cutting must be 90 degrees to estimate mechanical axis in corona and sagittal plane to get a angle parallel to the ground surface level. So almost a 0 degree ground talar dome ground surface angle, as you can see. And asymmetric distal tibia cutting, as you can see on this left picture here, is quite often necessary to have good alignment, 90 degree to mechanical axis when the patient stands later on. So this is asymmetric cutting often needed. This is 79-year male patient, bilateral ankle OA with the deformities. You can see that he has a severe congruent varus ankle arthritis and quite severe pain. He has been doing a mountain climbing for many years, and he has been recurrent ankle sprains for 50 years. And now he has so severe deformities and pain, he just have to be wheelchair ridden, and his score is about 59. As you can see, it's a quite severe deformities bilaterally and with the pain. So why during the total ankle arthroplasty, this type of asymmetric tibia cutting to be the parallel to the ground surface level should be done to have a good alignment after the total ankle procedure. And deep tattoo release is quite often needed to mobilize the joint and to balance the medial and lateral side of the ligaments. And post-op 6 months, the tibia cutting and osteophyte decompression and ligament balancing. He has a good alignment of the total ankle with the lateral sliding biplanar calcaneal osteotomy also performed at the same time. And he has no pain and done bilaterally. And this is his both ankles performed in 2 years at post-op 2 years with about 1 year surgery interval between two ankles. Performed the same procedure. Is now without pain and well aligned, and is very satisfied with the results. And this is the pre-op deformities of his ankle. And this is another patient with severe pain. With the previous, she was a volleyball player, has a severe instability, recurrent sprains, and quite a deformed ankles. So as other procedure, you can see the asymmetric distal tibia cutting should be to the 90 degrees to mechanical axis, and also combined with because of she had 4 foot first rate cables. I performed the dorsiflexion first TMT arthrodesis of the TMT joint, as you can see with the one screw here. And now he's well aligned with the varus ankle arthritis with Achilles lengthening and first TMT dorsiflexion arthrodesis. So ankle arthritis with the combined cable varus foot deformities usually has a very incongruent varus ankles, as you can see. So for this kind of a varus ankle arthritis with foot deformities, just it is more than ligament balancing is needed to address the patient. So you need this patient usually normal aligned tibia, a varus tilted incongruent varus. That's why that you should not uh, do some osteotomy of the distal tibia, but you should correct the problems in the foot. So varus deforming factor is present below the ankle level. So you need some deformity correction at the foot level. So this is a 64-year female patient, degenerative arthritis, varus foot deformities, perform with mobility total ankle with first TMT dose flexion arthrodesis with calcaneal osteotomy. Another patient, 78-year-old male patient, is a very severe incongruent varus ankle, but it's a quite neurogenic varus foot deformities with a talar tilt of 30 degrees. And so you have to address the patient with the delta release, biplanar calcaneal osteotomy, and endoplasia release, and first TMT dose flexion arthrodesis. So as a course of 13 months, you can see the well-aligned ankle compared to the before, which was like this. And the well-aligned also addressing the varus deformity at the same time. So this was performed in the one stage, well-aligned hind foot. As you can see, after the surgery, pain is minimal, has a good hind foot score. Published about this varus foot deformities performed with total ankle combined with calcaneus and midfoot osteotomies. Good results compared to normal ankle OAs. And now this is another patient with chronic lateral ankle instability. So it's a problem sometimes. So some patients had many patients had previous chronic ankle instability and lead to some varus deformities. But this patient has persistent instability of the total ankle arthroplasty. So rather in arthritis patient had a stiff ankle and now the instability is gone, but after mobilizing and cutting the joint, you can regain the instability. So for this patient, after total ankle, I had to perform modified Brosson procedure at the same time to stabilize the lateral ankle laxity. So some of the patients who had a residual lateral ligament laxity, you have to perform some of these ligament procedures, such as even modified Christmas snook. But usually more commonly I perform modified Brosson procedure. And some patients who have persistent, quite a severe instability after the total ankle, then I perform the subtalar ligament reconstruction, as you can see. This was a 65 male patient. You can see the quite varus tilted ankles. And after performing a total ankle, there was some residual tilting of the varus. Cannot be has been a little overlooked, even with the LSC calcaneal osteotomy and the delta release. And after 4 months, you could see they're very much tilted of the talus because of the residual lateral ligament laxity, even though I tried to realign the hind foot with the biplanar lateral sliding calcaneal osteotomy. And this is really a big problem because if it's not well addressed, then this is totally a failure, and you can have to do something for this. So what I did, I found out that there is some first ray, the cables combined. So what I did is a redo of the delta release and the subtalar this ankle, lateral ankle level reconstruction with the free tendon, semitendinous allograft tendon, And also I also did elevating the first ray with the first TMT dose flexion arthrodesis. And this is a second poster 1 year, 2 months. So you can see the now realigned the parallel tibia tala component with the screws in it. And this is poster 4 years, 6 months after the surgery, well aligned of that teething, and now still it is maintained stable. So I strongly recommend that in some patients that has a chronic residual significant instability, you should choose to really stabilize with the proper ligament reconstruction as well as the alignment reconstruction with the bony procedures, mainly the osteotomies. This is another valgus ankle OA patient. Valgus ankle patient who is very much tilted and 72 female, but standing hindfoot alignment view shows quite well aligned, rather a little varus ankle. So much of the deformity is compensated at the subtalar joint level. After the thoracic ankle arthroplasty is well corrected. This is a 65 or female patient with valgus ankle arthritis with other flat foot deformities. So I performed thoracic ankle correction with the thickest polyethylene insert we can put it in to stabilize. Another valgus ankle OA patient, elevated. So if it's not too much deltoid ligament stretched out, in my experience, it's better to correct the valgus ankle OA with the thoracic ankle arthroplasty than the significant varus ankle instabilities. So post of 2 years is well corrected without pain. Another patient, this is a little problematic valgus tilted arthritis patient. Is a stretched out of the deltoid ligament with the insufficiencies. I used the corrected with the deltoid ligament reconstruction using a semi-TL graft tendon for incompetent medial side deltoid insufficiency. So it has been corrected, but later I found that this was a little failed, so I had to do redo of the deltoid ligament reconstruction using internal brace with fibular lengthening to stabilize this. It has a buttress for the lateral side, combined with so that stabilize the deltoid insufficiency with the internal brace. So some of these patients you have to do the procedures at the same time to do it. So I'd like to show you some of the recent cyto data. I've been using cyto 3 component arthroplasty for the past several years, for about 10 years. And some of the data shows that from 14 to 2020, we found that majority of patients are post-traumatic in the etiology, and male-female proportion is about the same. Average age 66. I recommend the total ankle arthroplasty more than 60 years, but my indication is about more than 55 years old. As about the additional surgical procedures, I had quite a big proportion of varus ankle arthritis. In my practice, I found that I used deltoid release for about almost 30% of the patients, and some calcaneal osteotomy, TMT dose flexion arthrodesis, and about 25% of Achilles tendon lengthening. But now I do much less Achilles lengthening in my thoracic ankle procedures, and overall clinical outcome shows 6.7 to 1.7 improvement. score from AOF score 49 to 85. Range of motion improved, but it's not so much degree. Overall clinical outcomes of the patients, the satisfaction rate is about 88%. As about the complications, I found that one of the major problems for this total ankle arthroplasty is about osteolysis. It's about 29% have the patient experience osteolysis, talus or tibia, much less about this ossification, heterotopy ossification. But even other implants, they reported quite significant high rate of the osteolysis. I presume that this may be the because of the micromotion of the implants and some of the crevice or cracks in the microscopic holes, which allow the creeping of the fluid inside the bones, showing on the bone cyst in the follow-up. So I think this has to be solved in the future for this total ankle arthroplasty patients. And other than that, there is a neuralgia or heterotopic ossification, but much less heterotopic ossification in my practice, and some of the wound problems you have to admit for this anterior approach. For the reoperations, have to address about this varustating post-operatively, medial impingement wound problems, or some of the osteolysis I've been doing with the cementation of the cystic area. So as for the take-home message, total ankle for the deformed ankle arthritis, you have to decide whether you can really address the patient. So you decide whether it's a good indication for total ankle. Then customize the surgical plan for the individual patient, and deltoid ligament release, the tibia platform cutting, 92 mechanical axis is important, and you may need the lateral ligament reconstruction or bony reconstruction for the cavus deformity. So ankle ligament balancing is crucial for the varus ankle, tilted ankle after tibia and tala cutting, and residual instability should be addressed with any present foot deformity correction ligament reconstruction. Thank you for your kind attention.
All right, let me pull up Dr. Mcgarvey's video.
Hi, this is Bill Mcgarvey. I'm going to be talking to you about stiffness and ankle joint replacement. I think this is a very challenging problem. I think we have great difficulty.
Are you guys able to hear it?
I think it continues to be a
Are you guys able to hear it?
Yes, we can.
Okay, perfect.
source of disability for patients, and its challenges for physicians who are doing ankle joint replacement and are struggling with getting their patients moving post-operatively. So I'm going to address some of the key features that I think are important and some strategies to address them. These are my disclosures, and I will disclose that I am a consultant for one of the implants that you will see used repetitively here. So looking at the scope of the problem, target range of motion for an ankle joint replacement should be about 10 degrees of dorsiflexion to 30 degrees of plantar flexion. About 80% of this should be achieved by 3 months and 100% by 6 months. After this, you're not going to get much more, so you need to be on this early so that patients can restore motion. The goal in an ankylosed joint, if it's stiff or previously fused, is about 20-degree arc of motion, as evidenced by Charlie Saltzman's publication in 2000. Looking at what some of our expectations should be, looking at Pajevich's work, average arc of motion in his work 25 years ago was about 36 degrees, but with a broad range. 50% of these had ankle equinus, averaging 7 degrees with a range of 1 to 20 degrees. And you can see throughout this publication and the results that are published here that this has been a long-standing problem for us to deal with. NECT also reported on arcs of motion in the 67 patients that they examined after total ankles and found, again, broad range, limited arc of about 18 to 19 degrees, with success being considered dorsiflexion at neutral. So stiffness continues to be rated as one of the leading factors of dissatisfaction and can lead to pain, poor mechanics, altered gait, and both physician and patient perceptions of suboptimal results. What we don't want is a high-priced ankle fusion. Looking at Bonin and his expectations and our expectations as well, we look at overall ankle range of motion in Bonin's work improving from 15 to 28 degrees with his Salto implant. Zaidi did a meta-analysis, almost 60 references, nearly 8,000 patients, and found that in general, across the board, ankle range of motion after an ankle replacement went from a 23-degree arc to a 34-degree arc. And so Bonin's thoughts were that the quality of life is better in patients with a fusion in neutral than with a stiff ankle replacement in equinus. What I do is I tend to break these down into three categories: through pre-op, intraoperative, and post-operative factors contributing to stiffness. We'll take each of these and then we'll look at the continuum. Preoperatively, you want to evaluate these patients because the function of arthritis leads to pain, which can lead to altered gait with external rotation and limitations in dorsiflexion. Mechanical block, again, limiting dorsiflexion. Abnormal mechanics with failure to move through a full range of motion due to pain or mechanical blockage. And then soft tissue trauma leading to scarring, also limiting the amount that a patient can walk normally. All of these can be addressed at the time of ankle replacement, but potentially maybe should be addressed earlier. Other causes are erosive arthritis or AVN that can cause collapse of the joint, stress fractures that may result from persistent pain or bone mineral density deficiencies because the patient hasn't been walking as much, and failed implants or subsidence or loosening that can lead to abnormal mechanics. And we'll see examples of each of these. The assessment should include a thorough history and clinical examination, looking at length of symptoms, what effects they have, how it affects the individual patient. What is the fractional range of motion, both dorsiflexion and plantar flexion, so you can expect what to see at the time of surgery and thereafter. Are there mechanical blocks? Is there swelling that's interfering with the range of motion? What do the radiographs show? Are there spurs, irregularities of the joint that restrict mobility? And then, of course, CT scan, which gives better detail on all of these things, including osteophytes, shape of the joint, bone loss, quality of remaining bone, etc. What's the patient's response to various treatments? Is it non-steroidals help? Do wraps and compression dressings help? How about activity modifications? A mantra in total joint replacement across the board, regardless of total joint, is that the best predictor of postoperative range of motion is the preoperative range of motion. And I believe that that stands firm with ankle joint replacement as well. So let's look at some of the features. What can we do preoperatively to help enhance the range of motion? Well, many of our sports colleagues attribute some of their success and their ability to get a good result to doing prehabilitation, getting the patient in rehabilitation prior to surgery. This is also leached into the total knee world, where joint replacement patients go to therapy in anticipation to try and restore range of motion, restore balance, and achieve better functional outcomes prior to surgery, so that their postoperative rehabilitation seems like more of a continuum rather than an initiation. And this has been shown to be very successful across the board. What about intraoperative structures, intraoperative obstructions? Well, the best treatment is to avoid some of these problems postoperatively. Do it right the first time, address all the issues at the time of surgery, and this will maximize your outcome and give the patient the best opportunity for a good optimum result. Anterior bone resection is tantamount for every ankle replacement that's out there. If a patient comes in neutral position or equinus and has anterior osteophyte formation, this will be removed as a matter of course as part of the procedure. We know that. But one of the things that tends to be ignored beyond taking out the anterior osteophytes as shown here is the posterior capsular restriction. When there's anterior osteophyte formation, the posterior structures, including the Achilles, but not limited to the Achilles and including the capsule, is critically important. This is something that I spend a lot of time with intraoperatively. You can see here that I take time working lateral to the FHL. This is my barrier against the neurovascular bundle, to be able to release the soft tissue structures off the distal tibia and the posterior talus all the way back to the trigonal process to release off the back of the fibula. And then if you're careful and can identify the structures, you can work around the back of the medial malleolus as well. Again, an aggressive posterior capsular stretch or even a release is very helpful in restoring range of motion. It's the first step after bone resection that I look at is what kind of capsule is left. Oftentimes a good portion of the capsule will come out with the posterior distal tibia, but not always. And if it's still a restrictive structure, you can have some benefit by using this device and other devices such as curved osteotomes or some proprietary instruments to help release some of that posterior capsule in nearly a 360-degree circumferential approach. You have to be careful, and sometimes I'll even do this with the tourniquet down to identify the area of the neurovascular bundle. The next step is to address the gutters. Steve Haddad has popularized this as a technique, and it's critical. The gutters themselves are absolutely restrictive in some of these patients because gutter overgrowth prevents dorsiflexion of the ankle. And so you see here, I use a long snouted rongeur first to get osteophytes and soft tissues out of the way, working in the medial and lateral gutters to release as much as possible, all the way down to the subtalar joint on the lateral side, releasing the lateral process of the talus. Then I use this device, a reciprocating rasp. You can use a burr if you prefer, but to get in there and make sure that there is wide resection, both on the talar side as well as the tibial and fibular side, so there's no friction, no restriction in this area. I'll often put in my trial implants and then repeat this process to see if I can get better mobility after the implants are in. At this point, you want to look at extrinsic structures. The posterior capsule has been released theoretically, and then you want to look at your Achilles contribution. Many of these patients have Achilles contractures, and you want to do a true silver scale test to see if they improve with knee flexion or not. If they do, consideration to a Strayer tenotomy may be appropriate. If they don't, as many of the post-traumatics don't, then consideration to a true Achilles lengthening down in the level of the tendon is probably more appropriate. You have to be careful about how much you lengthen, but quite frankly, in many of these patients, a more aggressive approach will allow for later healing and they will reestablish some level of push-off. In my hands, post-operative splinting is really critical. I think compressive wraps, as Steve Haddad has popularized with his publication in 2015, have become very popular, and I use these as well. But maintaining the position of the ankle in its new found neutral or dorsiflex position is critical in the postoperative period so that the patient doesn't redevelop their equinus contracture. Postoperative therapy is really important, and so we have to negotiate between incisional healing and the initiation of therapy as early as possible. I like to look at my incisions within a week, and at that point, if the incision looks stable, I'll introduce some level of range of motion, whether it be self-guided or therapy-guided, at a physical therapy facility to the patient, because I think it's really important not only to reestablish dorsiflexion, but to promote tendon glide from the anterior tendons after they've been repaired. And as a sidebar, I think it's really critical to get a good capsular layer closure and then subsequently a fascial layer closure so that the tendons are not adherent anteriorly. Again, positional splinting I think is really important postoperatively to maintain the position of the ankle and to prevent equinus contractures that can occur with the patients resting and non-weight bearing for prolonged periods of time. Postoperative considerations are mostly focused on gutters and bony impingement. If you've gotten intraoperative correction and improvement, then where you're going to run into trouble is gutters. And you can see here in this magnified view that the medial fibula and the talus itself will form gutter impingement, as you can see here outlined nicely. Addressing this by resecting these areas intraoperatively, as you can see under the fluoroscopy where the freer elevator has no room to be introduced until after the bone is resected, demonstrates the degree of the problem. Aggressive resection is critical in reestablishing motion. And this has been a long-standing consideration going back to Spurt's article in the late 90s, demonstrating that 19–20% of these patients having revision surgery are due to gutter impingement alone. You can see here in the postoperative views of the patient that I showed previously, a wide and thorough gutter cleanout to allow for better mobility and better mechanics. Additionally, aside from medial and lateral gutters, you have to look at posterior consolidation. The capsule can act as a conduit for bleeding and this can lead to synostosis from the tibia down to the talus. This has to be considered. In this patient who was 5 years status post ankle replacement, he had no range of motion. And so this particular problem restricts plantar flexion and dorsiflexion because there is essentially a functional fusion. In this individual, a 360-degree approach is adopted. Posterior approach through the Achilles, trans Achilles, with lengthening anticipated after resection is performed. A posterior approach allows for direct identification of the bundle, and you can address aggressively posterior bony buildup, capsular contracture, and even tendon contractures. Once this is released, the medial and lateral gutters can be addressed from posterior as your bundle is already identified and protected out of harm's way. You can free up your gutters posteriorly before addressing this anteriorly. Repair is performed of the Achilles tendon with about a 1 centimeter lengthening repair, and then this can be addressed anteriorly. You can see the posterior release of all the synostosis that had been performed. Now we go anteriorly, and you can see the good range of motion that is achieved after releasing the medial and lateral gutters from anterior. And you can see the wide resection, again, medially and laterally in this patient. Now there's visibility from the medial gutter, lateral gutter, and the posterior synostosis no longer exists. Posterior capsular contracture is also a consideration. In this particular individual, you can see she's walking on a fused foot, basically a block of wood, with a significant contracture posteriorly. In this individual, we did an aggressive resection posteriorly and installation of a standard implant, and you can see that she achieves better than neutral dorsiflexion now, as she had been walking in plantar flexion and requiring a heel for years preoperatively. You can see she stands at neutral and she achieves dorsiflexion, as you saw in the postoperative and intraoperative radiographs. However, this patient ran into a difficulty, which was anterior contracture. She actually had the anterior tendons become restrictive and could not achieve her heeled shoe wear and use gas pedal or brake pedal in her car. In this particular case, which is becoming more prominent in patients where they focus on their ability to plantar flex as well and to be able to push off, I use this device to be able to reestablish plantar flexion. In this particular case, rather than reestablishing dorsiflexion with a frame, we actually force the foot into plantar flexion to stretch out the anterior compartment structures. And in doing so, reestablish the plantar flexion so that this patient now had not only dorsiflexion, but plantar flexion reestablished and could stand in a neutral position. So she could wear a heel, use a gas pedal, push off with her stiffened foot. And this was a success for her. Lastly, we're going to talk about the contribution of failed implants. We're going to see this as an increasing source of stiffness because these patients are going to increase in number as we implant more primary total ankles. We will, of course, see more failures over years, and we're going to see impingements as patients start to notice that their implants are starting to subside. And this was the original treatment for that, which was hindfoot fusion. But I think as we see better workups with more thorough evaluations of what's going on to assess bone loss, structural abnormality, amount of bony lysis and remaining bone, we can start considering that these patients will not necessarily require fusion, but can be candidates for ankle joint replacement, as this individual who has this failed implant shortening and stiffness undergoes this revision with gutter clean out and subtalar fusion to reestablish his ankle joint motion. I think that as we move forward, we're going to see these patients because we now have revision componentry that can be used as it can be in other joints. So I'll highlight that in this last case with this patient who had an ankle joint replacement done and got 15 years of good use, but started noticing severe stiffness, pain, and swelling. And as we got radiographic evidence, she had significant subsidence of her talar component. You can see that the tibia has subsided into the talus, not allowing plantar flexion nor dorsiflexion. She had been proposed to have ankle fusion or even amputation as she had moved out of the area, but she came back to see me and we talked about the possibility of doing a revision ankle arthroplasty in a staged fashion. In this particular case, reestablishing length was critical. You can see the collapse and the subsidence of the joint and the failure of the ankle completely. In this particular case, I reestablished length by applying a small wire external fixator and distracting and reestablishing the soft tissue length. As a staged procedure, we established bone stock by trying to do a subtalar fusion with remaining bone and putting a spacer in while soft tissues healed around this. And stage 3 was to come back and place an ankle replacement with revision componentry. The patient was able to reestablish not only length, height, and function, as well as pain relief, as you can see here with the standing radiographs of the ankle joint replaced back into her ankle and reestablishing her length. But you can see here that she was able to reestablish functional mobility and range of motion through the ankle joint with an ankle joint that was able to dorsiflex and plantar flex in reasonable fashion. So in summary, stiffness in total ankles is a difficult problem and should be addressed throughout the preoperative and perioperative period. You need to spend time in the gutters and in the back of the ankle as needed. Measures should be taken to ensure the mobility in all phases of treatment, but particularly at the time of surgery. Early and directed rehabilitation is likely a key component of treatment, as much or more so in the ankle than in other total joint replacements. And future directions, I believe, should focus on getting patients weight-bearing as soon as possible and reestablishing normal function with physical therapy so as to restore motion in an earlier phase of postoperative care. Thank you.
Excellent. That was just on time. So, Dr. Jung, we are out of time. 24 hours, done. Thank you guys for having this 24-hour period of time with me. We don't have any questions either. So I wanted to thank CurveBeam AI for sponsoring the last session of the 24 hours. I know everybody did not see every minute of the 24 hours. So in the next few weeks, it will be released on my YouTube channel. So if you go to the YouTube channel and you subscribe, you'll be able to get notified when these videos are released. Have a great weekend, and thanks for hanging there with us. Thanks, Johnny. Thanks, Dr. Jung.